I want to thank everyone for coming this evening to hear our amazing speakers. We're here to help provide informative and quality programming. We like to focus mostly on long-term planning, creative housing, daily living, social aspects of life, and some great resources for our loved ones. Like today, we also want to hear about topics that you're interested in that we can help support our loved ones. We don't have all the answers, but when we open it up, and as a group, I know we are a fierce force to help our kids. So with that, I will pass this along.
So I'm really, really pleased to introduce our first speaker, Dr. Alda Maria Gonzaga. She's certified in pediatrics and internal medicine by the American Board of Pediatrics. She's affiliated with UPMC. She's originally from Maryland, so I'm also a Maryland girl, so we have that in common. But she completed her medical degree, residency, and fellowship at the University of Pittsburgh School of Medicine, and she never left Pittsburgh. She's trained in med peds, and for those of you who don't know what that means, it means she has training in both internal medicine and pediatrics. So she is particularly well suited to care for patients with chronic conditions that may have spanned from childhood to adulthood. She was hired to become a physician at UPMC in 2005 and was asked to start a transitional care center, which led to the creation of the Progressive Evaluation and Referral Center, or PERC, which is a primary care clinic for patients with complex medical needs. This is a very unique center in our community. And now she's grown it to the point where they actually have 4 physicians working at the center. That's correct, right? Okay. She is also, in her spare time, the Dean of Student Affairs at the University of Pittsburgh School of Medicine. She's a mom. She's got beautiful kids. And why I don't know this is because she is also my son's primary care physician. And we have felt very well taken care of by her and her practice. So I'm going to turn it over to her. She's going to talk a little bit about her experience, what it's like at the PERC, and anything else that she feels we need to know. So I'm going to turn it over to you.
Yeah, thank you. First, thank you so much for inviting me and for welcoming me. And it really brings me a lot of joy to see parents of my patients in the audience. I appreciate the friendly faces. Maybe I'll start with how I became interested in this work. So in college, I worked in the summers at an extended school year program for kids with intellectual disabilities in suburban Maryland. And I absolutely fell in love with the kids and seeing them in that setting that was not quite as rigorous as during the school year. We got to see their personalities come out, and interestingly advocated for some of the end of summer programming to be around their interests rather than driven by the teachers. And I also, as a person who was a science major, really became interested in the why were they made the way they were made, and why were they as special in their own unique ways. And so that led me to think about medicine. And when I came to Pitt Med, I thought I was going to be a pediatrician. How many of you have experience with the Child Development Unit, which I don't even know if exists? Okay, great. So they were my first mentors: Sarah Hamill, Bill Cohen, Heidi Feldman. So my first summer of med school did research with Heidi on autism. She had a data set that I looked at and had a great summer with them. And then that summer she took me to a conference at Carlow about autism, and I heard people talk about being an adult with autism or having a child who's an adult with autism. And I bought Temple Grandin's book, Thinking in Pictures, which if you haven't looked at recently, Oliver Sacks writes the foreword, and he writes about how we almost always think about people with autism as children, not as adults, as if they have been whisked off the planet. And to me, that became a source of inspiration to bridge the gap. And so I learned about this specialty, combined internal medicine pediatrics, or MedPeds, and pursued that with the specific intention of doing this work. And then fast forward to being hired and being asked to actually start a program, which we call transitional care, but really it's about adult primary care, or adolescent and adult primary care throughout the lifespan. So other places in the country that have transitional care clinics, there are discrete time-limited stop where somebody leaves their pediatrician. This is buzzing and it's freaking me out. They leave their pediatrician and they
now
go.
it's working.
Yeah.
Are you guys okay, or do you want the
Do you
mic?
want it?
No.
Maybe you want it. I don't know.
Yeah.
So, yeah, where folks go to a transitional care clinic is a way station, and then they do the transition and get folks ready to transfer care to adult-oriented healthcare. Whereas when I started our program here, it really was about what we found was needed was the prospective care. So that's why we're called Progressive Evaluation and Referral Center. The referral piece of it is really, we do a small amount of consultative care, primarily for folks who live several hours outside the city, where ideally they would have a primary care doctor locally to take care of colds, cellulitis, something like that, but then we would do the care management for them. Otherwise, for folks who are more local, we ask to be the primary care doctor. From the beginning, actually on the advice of Patience White, who got transition. Okay, got the last name right. She came and spoke a few years in, and she was very insistent that in order to provide good care, one of the things I'd been struggling with was an appropriate handoff from the previous provider. And she was like, you shouldn't schedule them until you get a transfer note. And so that's what we instituted, rather than us trying to comb through stacks of records, really insisting on a transfer note before we would schedule patients. So we now have 4 MedPeds trained physicians. We are the primary care doctor probably for about 95% of our patients. What else was I going to say? I need to look at my notes. This is why I brought notes.
Transitioning advice.
Oh yeah, no, I'm gonna get you. What else do I need to say about the program? We tailor appointment lengths. So we have been really supported by the Division of General Internal Medicine to be able to flex our appointment length depending on the needs of our patients. So new patients are anywhere from typically an hour to 2 hours, whereas a typical adult gets a 45-minute new patient visit. And then typical adults follow-up is 15 minutes. We see, occasionally for our elderly, we'll stretch it to 30, or for our very socially complex patients, 30. But for our transitional care patients, I'm probably seeing them between 45 minutes to an hour for follow-up visits. I do have a small group that 30 minutes for follow-up is doable. And that just gives us the time, one, for folks to, if they're a little bit late, making it into the building, it gives us some flex time there. It gives us time to get them situated in the room. It gives us time for me to fill out paperwork for folks for waiver programs, for Woodlands Foundation, for Special Olympics. And so we found that has worked out really nicely. Okay, so question about, you'll notice that I've used 2 words, transition and transfer. So transition, I'm a purist in this, that it should probably start at around 11 years of age for most patients. You guys probably could tell me better than what I know if that's happening or not. But I don't think so. Yeah, I don't think so. And so folks transfer care to me, right? They're not transitioning to me. They're transferring care. And typically what we'll do then is finish up the transition process, primarily through their subspecialty care, which most often has a longer upper age limit than what PCSM had, at least pre-Affordable Care Act. When should folks transition? That is pretty individual. And I will freely note that here, this is often driven by the economics of healthcare. My kids, I have one now who's a legal adult who sees one of my partners, and then my other one is 17. She still goes to Kids Plus Pediatrics. They'll keep their patients till 26. Yeah, so my adult child could have stayed there, but she was like, no, I'm out. Graduating high school, get me out of here. Which, I mean, and doesn't that say a little bit too about your adult children, where, you know, it's going to be individualized to them and their needs. But there can be some flexibility within pediatric practices. But I think, you know, there may be some, you know, as doctors, we love our patients. We really care about them. And sometimes we may not be like, no, let's stay until you're 26. You can stay until you're 26. There are definitely subspecialty groups at Children's that have different age limits. I think neuro is at 18.
Yeah.
They upped it to 21, 26.
My daughter just turned 24 and we just switched.
Okay.
But that was my choice, not theirs.
No, because for a while there they were saying 18.
Yeah.
Yeah. Then there were other places that said 21. Then we've got pediatric cardiology that'll keep them forever because they'll transfer them to the adults with congenital heart disease, part of their practice, which is wonderful. I also have, you know, maybe getting ahead of myself a little bit, I also have some patients who are very small in child size. And then the question is, if they need to be hospitalized, where's the right place to go? And there is not an easy answer to that. So I know that for some families, that has been a huge part of the calculus of when to transfer care. And I've definitely had patients where their PCP forced them out. I was their primary care doctor, but they were still seeking. When they needed emergency care or hospitalization, they would go to Children's. So that there really isn't quite an easy answer to that for our patients at this time. It's been broached a couple times with Children's, and it never really I think it's all being handled at the individual level. I do think that if they're grown-up size, they probably do get better care on the adult side with the right team. And then I think the last thing I will say, and then maybe I'll hand it off to Josie, unless you whisper, I should talk. One of you whispers, I should say something else. When I started this, one of my first patients that Sarah McIntyre at Children's actually transferred to my care was a patient who would spend months at Children's. And she transferred care to me, and her first hospital stay was 4 days. And she was fine. And so I think there is that's the cultural difference. And I don't know if Children's still does these months-long hospital stays that when I was in training, if they still do. Yeah. But on the adult side, I think that you know, that's a big priority is getting folks home. And I have always made myself available as a phone call for folks, like as an unofficial consult for my patients when they are hospitalized. Oftentimes I don't need to be called. I've definitely written up care plans for folks with metabolic disorders who need specific care plans in the emergency room or in the hospital, and that has worked well. But I've been impressed with the quality of care. the last thing, okay, well, that wasn't the last thing. I will say the next thing in my head. My husband's an emergency physician who works at Presby, and he not infrequently ends up taking care of my patients. And if it's one of my special needs patients, he'll call me up, put him on the cell phone. Just say hi. I'm like, hi. You've never seen my husband. There's a patient of mine that I have who came in and really did not need to speak with me, but he was like, I'm going to put you on. Like, oh, that's the only time he's actually done that. But he always does call me, hey, I've got your patient. Yeah, I love it. So that, I mean, that's another nice, at least for me, that's a nice thing that I have a slightly different perspective of that first doctor that my patients see in the emergency department. Yeah, I think I'm gonna pause there. Your turn.
All right, I'll introduce her. So, to my far right is Dr. Josie Badger. Josie is an incredible disabilities rights advocate and is the founder and principal of J. Badger Consulting, Inc., where she provides youth development and disability consulting services. She has an impressive educational background as well. She received her bachelor's degree from Geneva College of Disability Law and Advocacy, a master's from the University of Pittsburgh in Rehabilitation Counseling, and a doctorate from Duquesne University in Healthcare Ethics. And I think it's so fabulous that in 2012 she was crowned Miss Wheelchair America. Miss Wheelchair. I got to know Josie when she was the campaign manager. I think this is when I got to know her. And still is the campaign manager of the United Way of Southwest PA's hashtag I Want to Work. And if you don't know a lot about it, we're not going to talk a lot about it tonight, although if we have a few minutes, we might, because it's incredible the work that she's done to move our state legislature to allow people with disabilities on Medicaid to work and actually earn without having benefits. Make it it's a fair summary about it.
I think I should talk about that.
You probably should. And that, of course, works to improve the employment of people with disabilities. She's the lead field organizer and co-chair for the Family Care Act. This is near and dear to my heart, that supports paid family and medical leave. She's the developer of SAIL, which is the statewide advocacy and lobbying training program. She's on the Achieva board. I'm getting exhausted. She also founded Peacock, a nonprofit that will further support the needs of the disability community. And recently, and one of the reasons why we have her here tonight is that she was contracted by the FISA Foundation, which is an organization, a foundation or a community that supports women and girls and people with disabilities to lead their healthcare access initiatives. And tonight we're going to hear about some of the research that she has undertaken. I had the opportunity to attend a webinar where Josie presented, and there was a lot. I mean, I think that webinar was an hour and a half. Yeah. So we don't have, unfortunately, that kind of time, but it's a recorded webinar. So if you're intrigued by what Josie says tonight, you could go on and I can send you a link to that, or she can, because it's daunting what she's going to share. But that's why we're here, and we can affect systems change when we learn from people like Josie. So I'm going to turn it towards you.
Hi, everyone. It's Legendary. Hi, I'm disabled. So, it's great to be here with all of you tonight. I felt, as I was listening to the stories about Children's Hospital, I was like, oh, that's me. Oh, I know that person. Oh, I lived there for 11 months yet. So I totally get the growing up in the medical system phenomena that a lot of people grow up in and we don't talk about. My first birthday I spent in the ICU. Got lots of presents. Very cool. And then, on and off, really till the age of 7, once I started just being a little more stable. But what I've said in some of my videos is growing up in the system, you become a real weird person. So while other folks are learning their alphabet and ABCs, I'm learning about germs. I'm learning about washing your hands. And the weird part is, when you grow up, when everyone washes their hands when they come in the room and when they leave, is all of a sudden you are broken, sickly, and something is wrong with you. And so I grew up believing that. Even though, yeah, it's mainstreamed, that's not the right word anymore, I get it. But my parents were and are phenomenal in making sure that I was fully included, had a full social life, but you don't get rid of some of those feelings about being different, broken, less so. And so I developed stuff like OCD, which was super fun. Anxiety disorders. And so for a lot of us with physical disabilities or complex health conditions, we develop other things. And sometimes we don't talk about the other health barriers, like the anxiety, the depression, the obsessive compulsive disorders. And so I'm getting totally off what I'm supposed to talk about.
That's very good.
So when I was little, and I didn't really think about medical trauma back in the day, but my parents knew that I had some anxiety issues and took me to Children's Hospital psychiatrist, and he's like, does she have any reason to be afraid of death? They're like, did you look at her? And so, like, even now, we don't always recognize the full complexities of what it means to grow up with a disability. And so, obviously, that's where my life calling has come from, is that experience of growing up in a hospital and feeling different and broken. And so, growing up, I was the most anti-disability disabled person there was. I wanted nothing to do with folks with disabilities, camps, all the things. My parents really tried to get me to embrace part of that. But being the only person with a disability in my family, my class, I didn't know what that meant. And so I ended up being forced to attend a youth leadership event for youth with disabilities. And my life changed in a minute. I call it my God moment. All of a sudden, I knew why I was this way. That I wasn't broken. This was all something else. And I needed to do something. So what that has thus taught me, though, is that not every youth or adult with disability has that moment. Not everyone gets to meet people, like the amazing people I met at that conference, and they still feel like they're broken and they don't have a voice. And then what happens when they go into health systems that should be made fully accessible to support them, and they're rejected there too? And so I was lucky enough to be brought into the work of the FISA Foundation. I was on their board, which was awesome, but then into their healthcare access initiatives. And FISA has worked for a long time on accessible healthcare. And we will see all over the city amazing things that were directly impacted by FISA and their work. But what they really wanted to determine is whether the barriers, the healthcare access barriers, were the same here in Pittsburgh as they are all over the country. In fact, they are. We have great programs, but they're not everywhere. And so we then jumped into what were the main categories of barriers. And we really broke it down into three. The first one being access, basic access. So when I was transitioned from pediatric to adult medicine, I live up in the boonies, Wampum, if you have anyone in there, it's a Wampum base. But we do have a post office. But there aren't those transition clinics. There aren't the doctors, please, we want to take all your problems. So I ended up going to gerontology. So I went from pediatrics to elder care. Well, because they were willing to coordinate, manage my care, they were more used to complex civilians. And did really honestly had a great doctor. But I was like the cool kid in the facility. I'm like, oh, pop it in. I'm like 22 and everybody else is like 92. But that isn't normal. And why are we all of a sudden just going for anyone that'll take us? So we were talking about an individual who saw their dad, who's an allergist, just because that's a doctor that would see them. How many of us do that?
I have other stories.
I bet. We look at access. The access barriers from literally houses that were turned into clinics that don't have big enough door frames or ramps that are terrifying, to the doorways that aren't big enough, to not having accessible scales, exam tables. I still cannot tell you the last time a doctor put their hands up. But I'm pretty anal, so I do all my anal checks about my vitals and this one. So we have this barriers. I still go to PetSmart to get weighed. And so these are barriers that in 2025 we're telling with. And it's not just physical, it's communication, it's signage, all of those things that prevent folks with disabilities from having the true healthcare experience that they deserve, that their insurance at least is paying a lot for, and not being able to truly express what they're living. Then we look at the financial barriers. We know that it is not just the cost of seeing the doctor. We know that there's transportation, there's parking, there's co-pays, medications, etc. Then we barely talk about the time people have to take off to get to that doctor, especially for those of us in Wampum who need to drive an hour and a half to get that care. And somebody else might have to take that time off from work also. So we're seeing that folks with disabilities tend to need to spend about $16,000 a year for health expenses versus $3,000 for people without disabilities. That's astronomical considering the little amount of money that we often have. And the last area, which is certainly not least, is the discrimination and bias. And this is both based on the disability, communication needs, but also the intersectionality. So there were many quotes that spoke to me, stating that when they went to see their doctors, they had to look as white middle class as possible to get appropriate care. I remember as a child just internally cursing my parents out because they make me get dressed up to go to the doctor. And I was like, they just take my clothes off. Why do we have to do this? I'm not a dressed person. And a nurse had told them at Children's that the better dressed, more well-taken care of looking children get more care. And so that's what they did. And so we are looking at this over and over in Pittsburgh and across the country. As of right now, FISA today closed up our applications for some smaller grants. I'm really excited to see what opportunities come in. We are doing series of webinars. We have one that's they're from DEC, I want to say, but they've really started groups of doctors and various healthcare providers that want to be more accessible. We're having somebody from Disability Rights Pennsylvania talk about, obviously, rights and responsibilities for docs and for patients. And then we're going to do another one by this brilliant woman who both is disabled and has just amazing background in healthcare. that we'll be sharing, because I believe that was what you made. So if you're interested, go to FISA Foundation online. You'll find that. You'll find the video, the other webinar, and the full report. But what I do want to take a moment to share is, as you guys likely know, there's a chance Medicaid's going to be cut by $880 billion. That's medical assistance. People don't always realize Medicaid medical assistance is, but waivers are a part of it. CHIP is a part of it. Nursing homes, all of that is a part of this. And so I've been working with a really great group of advocates around just talk to your legislator, get one postcard out, get one phone call. But we need everyone. We need everyone to do this, because Josie calling isn't going to do it. It's all the people calling. And so I think that there's so much on all your plates. There's so much. I'm overwhelmed with life and with this big looming cloud over us of what if. And so I think that we need to all be proactive, even if you're not a political person. Because it's life or death or something.
Thank you. So we're going to have a little Q&A with just the three of us, and then we'll open it up for questions. Allison, I don't know if you want to do Q&A or I can. We'll figure it out. Okay. So Josie, you just touched upon a little bit on the first question. Advocacy, we can all do it in a lot of different ways. The focus of my question was going to be particularly in the healthcare system, what might you do to advocate? But certainly beyond that, and I can talk a lot about what's happening with Medicaid as well. It's not for tonight, but hopefully all of you are aware, as Josie just pointed out. So what might we do locally at a federal, thank you, Mark, state, maybe touch upon a little bit more, but maybe particularly within the system, and what are some of the things that FISA and you are hoping to do in terms of advocacy? I know during the webinar, it was a very cool experience where Josie would ask a question, and then all of us attending. How many people were on that webinar? Do you know?
150.
Yeah, 150 people. And we held back. So she would say, what might you all suggest we do to advocate for better health care equity in our system? And I love the fact that she said, we're going to do this in a waterfall answer. In other words, hold your response until I say go, and then everybody put your responses in the chat. Why? Because if there are people with disabilities on the call, it takes them longer to compose and think about their... I'm going to use that technique. I thought that was fantastic. But some of the things that came to my mind was start at medical school. Start with medical students. Dr. Gonzaga, maybe you can even talk about that. How do we train? I know, for example, my son goes to the special needs dental clinic, and dental students come and observe and are part of this care. What can we do? And maybe both of you could address that. What are some of the things we could do to change our system?
Well, when at all possible, getting that person with a disability to speak their own truth is huge. Not only because they're the ones that know fully. And I'm not saying they don't have to even use spoken language. If they help develop, a PowerPoint you can show on your phone, or pictures. I was little, something that I wanted people to see that I was a human. That I had my cats and my dogs, and that's really what I cared about. And that, I was more than that person lying there that felt completely out of control of my own body. So there's different ways to do that. And I think by setting that standard that you are deferring to your child or loved one is huge. And I think you've set that precedent that I believe a lot of doctors will then follow. And I think that the more you speak up for saying, hey, where's that accessible scale that's now required by Section 504? Where is that thing? The better. And to be honest, without verbally attacking, but about the barriers it took for you to do it in C. That's number one. If we start to look at the state level, Oh goodness, you could go so many directions. But honestly, I'm not going to speak to one issue, do this or do that. Legislators have no idea. They have no idea. There are a few out there, like Representative Dan Miller and others. I mean, there's some great folks, but they don't necessarily have any history with disabilities. So sharing the history of, like, this is who we are, this is the cool stuff, but here are some barriers we face. That is so important. Then we look at the photo stuff. And I don't even have the answer for what to do at federal level, but collective voice is so important. Sharing your voice with whoever whoever serves your community is huge. But I don't think, like, not just the healthcare. I mean, I remember how many doctors the sidewalks leading in front of their offices were horrendous. So sometimes it comes down to your county commissioners, your mayors. And so one of the things I push really hard on is go to the person that actually has the ability to change something. Your doctor probably can't change the sidewalk, but who can? There's someone allocating those funds. So there's so much to do. We only have so much bandwidth and realm of influence. So figure out what matters to you and for your time.
Yeah. So, at the med school level, I do think you did come to the med school less than 10 years ago for
So too.
the transition to residency course, and Betty Lou probably invited you.
That's exactly who did.
Yeah. And since then, we had a course called Clinical Experiences, and one of the subsections of that course was disabilities, where folks had to go and explore what a person's life was like if they lived with a disability. We have since gone through curriculum reform, and now that has been folded into our longitudinal alliance program. Yes. Where our students actually get a choice of type of patient that they want to follow longitudinally over their time at Pitt Med. And so some may choose, do you remember, you may not have even been given which category.
You mean that the
So-
girls that I have are
No, like when you signed up,
yeah.
did they recruit you for a certain category of patient, your child for a certain category of patient?
For special needs.
Yes. So there must be a special needs category. I'm sure that there's an elderly patient category, people living with cancer category. I know that there's different categories. I just don't know the details of what those categories are. Like I know one of my patients who has a liver transplant. He's a LAP patient, a lab patient. So there's these different categories. The downside is that not everybody's getting exposure to individuals with disabilities, which actually this makes me want to go back and ask about where, if they're not getting it through LAP, Longitudinal Alliance program, where are they getting it? Because I would be surprised if they're not getting it through some other place in the curriculum. I'm just not pulling it into my head right now. We have in the past had like students who are interested in we have a disabilities medicine elective for the clinical years, and so students have worked with me, with Dr. Bolova, who runs our Adult Down Syndrome Center, with Dr. Bellotti, who now runs the Pediatric Down Syndrome Center. Our Med Peds residents are often very interested in transitional care, so they'll work with us and at those sites. And then recently, interestingly, I had 2 internal medicine residents interested in spending time at Kirk to see what it was like to take care of adults with pediatric onset conditions. And so I think we're starting to get some more interest in just the internal medicine side of things, which was delightful.
Okay, good. Thank you. So this is in the same genre question, but if you could change one or two things in our healthcare system, what might that be? If you could dream big. I mean, who was it? Astrid and I were talking about the new Mercy Pavilion and how beautiful it is and how accessible. Why can't every building be like that? That would be one of my aspirations for, dreaming.
Yeah.
I'd love to see your office, get that.
Yeah.
So what would that look like? I don't know, whoever wants to hear it first.
Oh, geez. I think the really aspirational thing is better reimbursement for physicians, because then I think physicians will not feel as pressed time-wise. I think the reason the Mercy Pavilion looks so beautiful is because it's new building. No, and it's a new building.
Yeah.
Right? It's a new building, so it's being built under a different code.
That's true.
That I don't know if Montefiore, which is not that. I'm curious what the new Ben Tower will look like.
Is that what that new building is called?
The Ben Tower. Yeah, that's what they're calling it. The new Ben Tower. It's going to be for only hospitalized patients. I'm sorry, my sweets. We're stuck in Montefiore. And then the next thing is, I think, like, the next aspirational thing is just mindset, that I wish anybody in healthcare, whether it's physicians, nurses, that we all have that mindset of, seeing the humanity in its fullness in every patient that we take care of. And as I'm hearing you talking, I'm like, I'm not usually actually, maybe I am usually a glass half full, but I can usually find the not silver lining in a cloud as well. But I feel really blessed with the team we have at Montefiore. When I started the perk, I went around and had faculty meetings and then meetings with our medical assistants to make sure that they would mitigate their biases when they're taking care. And we've had so many MAs turn over. I usually am in the same little pod, and I haven't had to do it. They're all wonderful. And I always get the positive feedback about whomever is working with me. And so that speaks, somebody's doing something right with regards to mindset. And that also goes to our medical assistants and LPNs who are phlebotomists.
They're so great.
So many patients were like, can you reorder my doctor's the blood work they ordered so that we can get it drawn here?
I've never said that ever.
Yeah.
You want to go to the people.
Yeah. And it's not just one person. I thought it was one person, but it's not just her.
No,
it's all of them. Yeah. I have a patient who I've been taking care of for maybe 3 years, who is in her 50s. She has Down syndrome. I don't remember now off the top of my head how she ended up transferring care to me. I think she had come from another adult provider, but something happened. She came to me. She had not had blood work in years. I walked her down the hall, sat with her. She grumbled. She likes being ornery with me, but she's super sweet with the phlebotomist.
Good idea.
Yeah, and so I think there's also something to be said with that's the beauty of MedPeds in this particular setting, is that we're just going to roll with it. Let's try something new. Let's just play a little bit. And so we've been able to have, do some pretty cool things. We definitely have some patients. One nice thing about us being kind of in the hub of Oakland is that we have a relationship with the special needs dental clinic. So if our patients can't get blood work drawn while awake, we can have them get blood work drawn while they're being sedated for their dental exam. And we'll do vaccines up there. I have never done a gynae exam up there, but I I don't know.
Private up there.
No, it isn't. I don't know that it would work, but I think they'd be willing to try. But I don't know. I don't feel comfortable with that. I usually, along those lines, for those of you with female children, I nationally, my colleagues and I who do this work have started doing vaginal swabs for HPV rather than the speculum exam, and that actually has way upped my our screening rates. But I do also have conversations with families, because not all family, a lot of families are like, no, I don't think that this is going on. So we do a conversation, and without calling it a risk benefit conversation, that's what we're having, is a risk benefit conversation about, should we try to do this? And if not today, then when? Or should we not even talk about it as an well, I bring it up every year. But we all, okay, we're gonna be okay with it.
Do you know about Dr. John Harris at Mickey?
Yes.
Is he now running the women's with special needs
Yes.
at the clinic? Yeah,
He's
it
awesome.
keeps going through. The thing there is the wait. Yeah.
Oh, yeah.
But I have had some patients. I have some patients who only go to them. Actually, one of my patients saw Glenn Updike way back when.
Oh, I went to.
Glenn Updike was there, and now she refuses to go back because whoever she saw after that was horrible. And so Glenn sees her as a special patient. Yeah, but this is a way to do it with that. I've plenty of patients who would much rather just get it done in the office, not worry about sedation, and we're fine. But in terms of wish list, now if we're going, you went micro to big about advocacy. I'm going big to micro here. So we don't have a Hoyer lift in my office. We have a lot of things, but I would love a Hoyer lift. I would love to have a Wellner table or whatever is the new thing for strapping legs onto exam tables, if needed. Bigger exam rooms. Yeah.
It's incredible.
Yeah. We manage okay. We get it done.
Oh, you totally
We
get it
get
done.
it done. Yeah.
But it is that basic, right? Of just
Yeah.
the physical space of recognition, in some cases.
Yeah.
Josie, what's aspirational for you?
That's very strong.
In the healthcare system.
Yes. Some people might not like this, but universal health care. I'm so sick of this risk of losing Medicaid, or if you make too much, or it don't work, or whatever, this risk. Now, leading to what Judy had mentioned earlier with the I Want to Work campaign, one of the bills that we got passed was medical assistance for workers with disabilities, workers with job success. So basically, a person who needs medical assistance and waiver or whatever can earn really over $120,000 a year in those benefits. Now, it's not Social Security, but the help, which often, by health care is probably about $300,000 to $500,000 help a year. I couldn't afford to be successful. And so MOD gives me the chance to not only earn more, I could be a landlord. I don't want to. And we're able to get married because most of the time, household income tends to be less than that. And so from the passage of the bill, within days, there was an individual that got married to somebody she had been with for a long time. And it was so cool. Oh, so cool. But we shouldn't have to worry about that to be able to get health care. It should be about what do you need and what do you need to be successful to live your best life. But it's not. So I think that's one piece. There was conversation about looking at reevaluations of level of care that will be provided by waivers, by repeat. The one problem I see that we're all we're all fighting for the same pot of money. And I hate it because I'll look at some kids with intellectual disabilities who have aids for being paid over $20 an hour, and I'm not allowed to pay over 11. Now think about who wants that job.
Yeah.
If they can't go to work at Walmart or McDonald's, I mean, my 15-year-old foster son was making $15 an hour, and he was a terrible worker at McDonald's. And then there are people that are being charged with being my arms and legs, running my ventilator, giving me meds, driving me to Pittsburgh, who are being paid $11 an hour. And then after tax, he's not about dude. So then if they have kiddos, they have to pay all of that and more to get childcare. So I get a little perturbed about that because we need to be looking at the YouTube, not diapers.
Yeah.
Thank you. We have a couple more questions and then we'll open up for parents. So I didn't know if you wanted to give parents any advice for maximizing the time they spend with their doctors in these times when most of us maybe only have that 15 minutes, 20 minutes. What do you advise in terms of preparation?
Yeah.
Maximizing it.
How many of you see a physician who has a portal? Like a patient portal? Yeah. I would prepare a list and send it to them before the appointment. If you're time limited. My folks don't feel like you need to do that. You can, but you don't. We have time. But I would definitely. I have some patients who are complex in different ways than what we're talking about, who send me kind of their questions up front, and that's often very helpful.
She makes them really good at
And if not, I would just come in with your questions. And in med school, we're taught to set an agenda. Not all doctors do this, but I think that you could do it for them. Like, hi, doctor, I'm coming in with 4 questions for you today. They are bum, 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 bum. And then they can plan their visit on the fly.
And last question to Josie, what's up next in your work for the research on inequities and disabilities or in general? What are you up to next?
What am I up to? I'm that person that's like, I'll do it. When I'm like, when? And so what I started on Thursday was to start getting folks with disabilities, families, and providers together, just contact legislators about this Medicaid. Lord willing, by March 14th, we won't have to worry about this anymore. But there's going to be more things. And so getting the folks connected and getting them the basic understanding of here is how you talk to a legislator. Here's how you call them. Because a lot of folks, especially those with disabilities, are terrified to talk to them. They think that they already know all this stuff, so why call them? Or they don't listen. And so I feel like our community needs to be the ones at their door first thing in the morning. And so my hope is to create a little Pennsylvania army of folks with disabilities, loved ones who are trained to know how to speak to a legislator and have the support to do it. So I'm doing that. I'm trying to create online modules for this too on how to do it. Because some folks still have the time of day to be able to sit through classes, all this stuff. I've been working a lot in the men's mental health arena. I've lost people in my life to suicide, homicide that was totally related to mental health. And we're not talking about it. There's great groups for youth. There's great groups for, well, right now for the LGBT community. But we don't see many billboards or commercials with that. But those are the ones that are dying. So working on that and whatever else someone else is like, hey, will someone do this?
Well, thank you both. I mean, you're both incredible. I think all of us have learned a lot from just listening to you tonight. And now we'll open it up to you all. If you have questions for either of these two amazing people. I saw a gentleman in the back.
Yeah, hi. Thank you both for your part here. I'm Michael Smith. I'm a former, recently retired provider of service to both kids and adults with intellectual disabilities. And so my first question would be, you talked about barriers to service. Other than, well, it just maybe a comment might be that, and I'm sorry, I'm a father of the young woman with an intellectual disability. And so, as a service provider, I suppose I kind of came to find make a little list in my office of mental health providers, frankly, advocates and folks at DRN. So I had this sort of cheat sheet of folks who were sympathetic. And what advice do you have in terms of penetrating the system and just finding docs or clinics or nurses who they're sensitized to folks with disabilities, whether they be physically handicapping disabilities or intellectual disabilities. So how do we, other than networking with one another, there doesn't seem to be a way to kind of find the good folks.
Yeah, I think that never underestimate the power of networking.
Yes.
And sometimes I think even social media in 2025 is really helpful from a virtual network perspective. Next, I would say I would recommend looking for med-peds physicians. I've met lots of family physicians who are very sensitized to this as well, but med-peds physicians are often a little bit more bold to do this. I definitely have some contemporaries of mine from training who live in surrounding counties who are sensitized and willing to do some of this work for less complex patients. So that's helpful. Those are really the two big ways. Sometimes, actually, the other thing is asking current providers. Sometimes they may know of where former patients have gone for care and have heard whether or not things have gone well. Even pediatricians might be a good way to, like reaching out to a former pediatrician or to that group and say, hey, looking for a new adult doctor. Do you have any recommendations?
Okay.
Yeah. What are your...
I mean, I think that pure network thing is where it's at. In Pittsburgh, there's a disability mutual aid group on Facebook where it's folks with disabilities saying, hey, I got this, I would help with this. And they really are so generous with their knowledge, their time, and sometimes their resources. That group knows where to go, where not to go.
Oh, wow.
So it's on Facebook, but you'll find other places. But I think it's the folks with disabilities that are going through the steps, that are getting the terrible reactions, or the receptionists that won't let you talk to the darn doctor. So we left is in there. Those are the folks you need to be real and get your short list from.
Okay. Thank you for that. And may I make a comment now at the school? This is a tremendous being here. The comment would be, lately I've trying to find a kind of a fine line between advocacy and activism. Sure. And so my patience with advocacy wanes. And so I think, let's hope it's, so I was graced, I think, 3 years ago to have survived a heart attack and stroke and become a person with disability. So a little bit of a different perspective as well. So I got to be a provider of service. Have a daughter who's navigating the system and now the adult system. And then, pretty sure that God figured out that I needed some additional perspective. So,
Well, we're really glad you joined us,
Yeah.
and we hope you will be back.
Okay, put that sorry.
Thank you for sharing us. Anybody else? Let me see another.
That you're here is we do have some gentlemen here, but it's mostly women. It's mostly the moms.
that's why I came.
Yeah, and I mean, I know, like, I'm single. I'm divorced. My ex never shows up for anything from day one. And I would somehow like to see more dads involved, more dads to come to meetings, more dads that don't just say, "Oh, tell me if I need to know anything." You know, and I don't know how to. You know, I'm so glad that I see you guys here, but you know, I don't know how to do that. I didn't get likes to grant.
Well, snacks is always.
There you go. And I'm sorry, sir, that we didn't send you a welcome to the community basket when you joined the disability community. But, you know, it does mean you can join us at any time of your life.
That absolutely. And forgive me, but lastly, you know, I'll shut up, which is never easy, but a recent kind of observation for myself and my daughter is when we run into roadblocks or we're maybe not getting our needs and that there seems to be a recent trend to divert the winder patient to emergency room services. And all due respect to your husband's fine work being done at the emergency rooms, the physicians and the folks who work there, but emergency room care seems to be like pretty crazy these days.
Oh yeah. No, don't get me started on his commentary.
Certainly not the easy place for a person with an intellectual disability or myself that you have to have your patience cap on, if you will.
Yeah.
So,
I just wondered, in light of what's going on that we've touched on with Medicaid and changes and our children who have disabilities, my son has Fragile X syndrome and has intellectual disabilities. He's not able to speak up for himself, so he's dependent upon us. So I understand the individual advocacy of writing to our legislators, but if it comes to a time where we need group to show up different places, are there, can we look to the branch, or who can we look to maybe organize bodies as we need to get?
Yeah.
that
Well, so
advocacy?
Josie talked about some groups she's working on, so I think we'll get her to share that with us. I'm signed up, again, not to get political, we're talking about defending Medicaid, right? Ban, it's a Pennsylvania Health Network, Access Network. Robin Seeley is she's amazing, right? Astrid has had a conversation with her. I have as well. In fact, tomorrow night at 7:00, she's having a webinar. We'll get it out to you guys, right? Yeah. There's one at 2:00 and one at 7. Robin Seeley. Yeah. Anyway, we'll get information about Achieva. I'm sure is going to be doing some great work. I'm actually going to be meeting with Mary Hartley this week. So if you got, we can share this information. It's non-political. It's just, I'll think, Nancy, are you comfortable, sharing some of this advocacy? Nancy Gale over here is the executive director of the branch. That's what we're here for. We're here to empower ourselves. And as Josie said, it's not hard to make that phone call. Robin Houtman's be looking for stories. If you're willing to share your story, just things like that. I called when the first budget stuff was coming out. and there was a click, and actually I got the wrong representative, and so I ended up going to Chris Luzio's website and got his phone number and called the office, talked to a real person.
Yeah.
I mean, I was shocked, right? And I said, this is my story. It takes 30 seconds. So there are things we could do, and we'll get some of that information out. I don't know if you guys want to add to that.
Yeah, that's what I've always heard. It's the personal story. I mean, there may be, those kind of robo emails like sign up, but what I've always heard is to include a personal. You can use that as the skeleton, but then include the personal story, because that is what makes the impact.
The other argument is that how many of us in this room wouldn't have been able to work if we didn't have those home and community-based services that helped us with our children so that we could work? Or how many of us have not been able to work because we're taking care of our kids? So, and that's a great economic argument for why Medicaid is so important as well. Did you have anything else, Josie, you were going to
So I was just asked about that advocacy versus activism work, and there's an interesting line there. And one of the big lines is, no one wants to fund activism or lobbying. And so, unfortunately, every issue becomes an educational opportunity. And so one of the things that I am just so privileged to have is, since I have an S Corp that's not funded by anything government, I can lobby. And so that is why I started doing the City of Medicaid work on Thursday. But since Thursday, I've gotten 100 folks from the area involved doing letters. So if you guys are interested, give me your email, and and rename, and I will at least get you the link to sign up for stuff. We are working on branding with social posts, but we're trying to get lined up because fan is wonderful. And my gut tells me that once they see 100 emails from a fan there, and they don't basically agree, they're not going to read the rest. And so my gut tells me that we've got to go out individually as well. And so trying to make that as accessible both for folks with disabilities and families that don't have the darn time to do all the things that it takes to have to do activism. So, yeah.
I just wanted to, I know Mark has a comment also. I wanted to bring into the conversation the UPMC Disability Resource Center, because that center is a great resource for all of us if you get your care through UPMC. I'm not sure about the AHN network, but how, what kind of mechanism they may have. But it's good if you know you need something in advance that you think you're not going to get. We talked about a Hoyer, like if need to get up on the table, whatever. So in advance, but also if something doesn't go right because of the disability, because the way the disability was regarded in the office. And we've made numerous calls when things have not gone the way we wanted them to because it's the way we needed them to go. And they will look into it. They will get in touch with that office. They will talk to them about it. It's not necessarily like the office, the person or office that you reported is going to change anything that they're going to tell you about, but you have to think about it as education. Just the fact that you said that didn't work for you, it's a communication. So wanted to call them out because I think they do a great job. You have something.
Some sick go back to Children's Hospital, especially orthopedic.
Did you hear that?
Yeah, something about some
Back
kids go
to
back.
children's. Well, Mark is 29, but sometimes you can't find the specialists that you need in the adult world. And honestly, Kate Wood said, call your pediatric specialist and see if they'll still take you, which seems very unlikely to me. That should not be the case, that you can't find an adult, especially in the city of Pittsburgh.
Yeah.
Thank you. Thank you, guys. Thanks, Mark. Anybody else?
got a couple more.
I was downtown on Friday.
Where were you?
Yes, I was in the crowd.
Were there pictures of you with a sign?
Yes.
I didn't have a sign, but I was in the pictures. Yeah.
How you doing?
Yeah, Angela was in there. And as wonderful as I love being there doing that, I feel like we're speaking into the void, so to speak, because none of the opposition is there to hear us. Everyone there wants for us and wants to fight for us, and I want to get, I'm sorry, into the faces of the people who want to say your child's not going to have this or to thrive with what he needs. How do we do that? Is there a way? Because you can't even get a hold of their offices.
Okay. Showing up is one method. 90% of the time, staffers will at least talk to you.
Okay.
Sometimes you'll get opposition. Get your happy little self out for every minute of it.
Okay.
But when you are able to have a good interaction with a legislator, ideally with your son or daughter there, get pictures. They love media of themselves with those poor little kids with disabilities. I'm being facetious. But getting them to build some commonality of like, hey, this is a real person. Hey, we're in your district. Huge. Phone calls when you can, but I've had the same issue with certain offices.
Right.
And if you look up who their donors are,
Okay.
figure out if any of those donors may be sympathetic to you,
Okay.
they are real likely to be with somebody if that donor gives their office a call.
Okay. Well, that sounds great. I have one more. I'm
Yeah,
sorry.
go ahead.
I'm sorry. I should have said it too. With medical, it's dental. We are lacking
Yeah.
so horribly. You know, we go to Pitt Dental.
Yeah.
My son can only be seen maybe once a year,
Yeah.
which is
Yeah. Because they're
horrible.
overlooked.
They are,
And
but they're good.
They're
and
great.
yes, they're good.
They're good.
And God forbid you miss that appointment.
Right.
You're done.
Yeah.
Or if you have a pain or a toothache. or
Oh yeah,
something,
trying to get in. I'm not going to go into our thing with the wisdom teeth thing, but it was very, very bad. We were in the ER. My son quit eating and drinking completely.
Yeah.
No one was willing to take his wisdom teeth out. They were just like, well, we're booked.
All the oral surgeons.
Children's finally did it, even though he was not any longer seen by Children's Dental. They took him in and did it. He was I was crying. He's going to die. He's not eating or drinking. He's this big as it is, although he eats constantly. But he's very tiny. And yeah, all we kept getting is, we don't have anything. So that, and then the people I see at the dental clinic drive like 4 hours from like upper Pennsylvania, the state line, because this is the closest thing they have.
Yeah.
Is there any way to change this? I know there's a couple places like Miracle Dental and
Accessible dental.
but Miracle Dental only goes to a certain age.
Yeah,
They
okay.
kick you out once.
Okay.
Yeah. And I think Accessible Dental does it, but they're overwhelmed too because
Yeah,
that's
they
literally
become-
it.
Yeah. I've been trying to collect the names of dentists. Dr. Ehrenberger, the new director of PERC, has a more comprehensive. She has collected a comprehensive list, so
Okay.
there are.
I have the list. Yeah, I'm pretty sure I posted it in that group.
Yeah.
I didn't hear any more.
Mark?
Singing has the E.
Yes, the
Oh, okay.
email address.
Oh, good.
Because my son needs to be sedated, so that's a whole nother
So
ball.
that's the other problem. I have a lot of patients who, or a collection of patients, if you will, a group of patients who have local dentists who do see them, but they don't need to be sedated. Once you have the sedation, they don't want to have the so
Right.
exceedingly difficult to find sedation.
Okay.
Josie, I have an advocacy question. We've sort of been talking about this. Whenever I call a legislator's office to say, please vote for this, please, don't vote for this, I I always speak to a staffer, an intern, somebody like that, and they're usually very nice, and I tell them what's going on really briefly. It takes a minute.
Yeah.
And that's it and goodbye. How I always imagined they have a list. 1 for, 1 against, 1 for. Everybody that calls, that's all they do is check off. And at the end of the day, they see they have 10 people who want you to vote for this, and they have 100 that say no. Is that what happens, do you think? And is there a better way? I mean, of course, showing up would be better. But is that how they do it? I feel like.
To some extent, I think you are right. Now, what I've heard from legislators is that if they get email or call from more than 10 people as their issue, then that is elevated as pro, con, whatever. I think that the stories stick out, that's huge, but what I have found is if I call an office and say, I have 5 people with disabilities in your constituency that want to talk to your representative so-and-so, we'd like to schedule an appointment with them. That's where I tend to get the best luck. Because staffers are great. And some of them are more willing to listen, but some of them will also swing out turn and say, oh yeah, we're dying. The legislator never would. And so, you know, if it's something important enough and you're able to bring a few folks together, that's huge. If you can name drop an organization you're with, huge. Which, I mean, usually I say, I'm Josie, I'm from blank, or I'm from, so blank. Sometimes I hit through, sometimes I don't. But I think that the name dropping, plus saying if you're with a larger group, that's where there's power.
And even if you know that they're supportive of a certain bill that you want them to vote for.
When
Is
it's
it more-
possible, thank them.
Okay, that's a good idea.
When that's possible, drop an email, drop a call. Hey, I'd like to thank Representative so-and-so for supporting this work. Give them your name to make sure they know at some point you called and thank them for something because they do track them.
Oh,
Okay.
that's.
Thanks.
So we're actually, I think, at time. We're going to end the formal part of the evening. Please stay if you'd like till 8:30. If you want to just do some networking or talk to our fabulous speakers. You guys are amazing. Thank you for everything you do. They're so busy, and for them to come out tonight is really a gift. And we appreciate you.
Thank you.
Thank you very much.